take for instance you are a doctor, a pediatric immunologist, which means that you study toddlers and children and you study the immune system. And take for instance that you've been a doctor for 10 years and you had this one patient, 5 years old, who's been coming back for around 2 years. This patient has Kawasaki disease and you find it a problem. And this is because, well, this child was diagnosed early at 4 years old. By the time he was 5, the disease didn't go away. This treatment you gave was not responsive, and the child is still with problems. So, back to the basics. What is Kawasaki's? Kawasaki disease is an autoimmune disease that affects primarily children across Asia and Southeast Asia. It was first documented by a man named Tomisaku Kawasaki in 1967, and he documented that these children would come in with fevers, rashes, enlarged lymph nodes in the neck, and the strawberry tongue. And the problem with Kawasaki's was that it often inflamed the coronary arteries like this. So the coronary arteries are arteries that supply blood and oxygen and nutrients to heart muscles. The heart is also a muscle and needs to be well stocked with nutrients. And Kawasaki's can often block arteries like this and often cause aneurysms. And aneurysms are when these arteries balloon up like a bulge, and much like balloons, it can pop. And when an artery that supplies blood to the heart pops, the heart is in big trouble. The heart can experience muscle death, which means a heart attack. Blood can pool around the heart, and there can be valvular dysfunction. The valves cannot be working very well. And this inflammation primarily arises because, as an autoimmune disease, it basically means that Kawasaki disease is an allergy to your own body. An allergy in which scar tissue forms around the blood vessels. However, the problem with the disease is not only the morbid results, it's also because there's a pure lack of research. The causes are unknown, how it works inside the body is unknown, and the treatments are largely based on trial and error since the 50s and 60s. And so go back to the analogy, and that you're a doctor dealing with a disease, and you're giving this child basically a trial and error treatment, IVIG, to treat this coronary problem. If left untreated, as said by Cato, this could lead to really bad problems for a child. And most of this research has been collated by a woman named Mary Beth Sun and Newberger in Boston. The problem gap is that while IVIG is known to be the best treatment, although it is only 80% effective, as recommended by Yuhira in her study, the problem is that the secondary treatment is often left unknown. There are options such as steroids, there are options such as IVIG, continuous IVIG, and there's other options such as infliximab or aspirin, which hasn't been studied much yet. However, I'm just looking at those who are unresponsive to IVIG, much like the patient we first talked about. And the problem is that there's a lack of concrete evidence for secondary treatment. And I am primarily studying steroids, because steroids has been a rising new alternate treatment for Kawasaki's. And there's research on both sides. In the early 60s, Cato has studied that steroids could actually make the problem worse and have the coronary artery aneurysm stay even longer. However, more recent research by Miura has showed that steroids was actually an excellent option and that rapidly decreases the coronary artery aneurysms. And so my research question can be easily condensed down to two ideas. We're comparing IVIG versus corticosteroids as secondary measures. So basically, when a child comes in, is diagnosed, is given IVIG, and the IVIG fails. We're comparing whether continuous IVIG is a better option or if continuous steroids are a better option. And my thesis found that it is actually equal. The effects are actually equal, and they're equally as effective in dealing with Kawasaki disease. And this can be easily boiled down to a focus. So I am suggesting a use of alternate corticosteroid treatment, which is also called IVMP. And IV just stands for intravenous, which means the method of application is through the vein, through a pipe, through a bag of methylprednisolone, which is corticosteroids. And so we are suggesting this use to a patient, and we are measuring the coronary artery inner diameters over time. And the reason why I'm measuring this is not only because it's a logical conclusion as this is the biggest problem, but it's also because the Zorzi found that this measurement over time is the most significant risk factor assessment for the progression of this disease over time. And all my subjects are going to be children in Singapore who are unresponsive to primary IVIG. My method is a retrospective observational study. It's observational, meaning that it isn't an experimental study. And this is done because while experimental studies can show easily causal relationships, but observational studies are better in that they show more accurate results of what a treatment is like in the real world. Furthermore, it's retrospective, as Kawasaki disease takes over like 2 or 3 years to manifest and fully develop and fully get healed. Only a study that studies patients in the past is most effective and most timely. And it's an observational study, again, because we're only analyzing clinical aspects, not the actual experimental lab studies. And we're using quantitative variables so we can mathematically just define with a certain level of certainty exactly how significant our results are. And this design is generally adopted by most biomedical clinical studies, but Dzorzy, again, in her study, used this exact same study, and Han, in his study, found that an observational study is actually beneficial because those who are different races have equal responses to treatment, and those who have equal ages have equal response to treatment. So randomization isn't as big of a problem. And my method can be further boiled down to this simple flow chart. So all my patients come from the Electronic Medical Record Exchange, which is the Singapore's own public healthcare initiative to collate the patient case notes for all kids who visit public hospitals. There's like 9 of them. And I have 78 kids who received secondary corticosteroids and secondary IVIG. So these 78 kids over 15 years have been unresponsive to primary IVIG. And thus we measure, or we look at the data of the 3 coronary inner diameters over time, and then we compare it using stats. And this would be my sample data for the evidence. It is quite overwhelming, but to simplify easily, one line is one patient, and that would be their ID, their initials, date of birth, or just demographic information. And for each day, this would be one day actually. We would collect their weight and height. We would collect the 3 measurements for the arteries, and we would standardize them for a population so it's easily comparable between different weights and different heights. And so this is actually, it goes on for maybe 90 more rows, 90 more columns, and 78 patients, so it's quite a big spreadsheet. And my results can be boiled down to this flow chart. So we're comparing corticosteroids and IVIG, and the demographics help because it helps check whether randomization was correct. And so there was no difference in gender ratio, so it's check. No difference in type of Kawasaki's, whether it's incomplete, atypical, or normal Kawasaki's. There's no difference in age of onset, and there's no difference in symptoms. And this is a check because I could easily verify whether my data was skewed because one population happened to be more male or whatnot, and we found that there's no difference in coronary artery aneurysm resolution. And it is done through multiple Kaplan-Meier analyses, which just measure how effective a treatment is over time, essentially. And my explanation could be found with 2 sources. Okada stated that steroids is a good option because it often decreases the amount of immune signaling so that the immune system isn't as hyperreactive. And studied by Tsumoto, who found that IVIG actually induces the death of many other immune cells. And so this explains why these 2 treatments could equally be an effective treatment to decrease the immune sensitivity and help cure Kawasaki's. And the significance is that, again, the controversy is that there's a lack of evidence pointing to any which treatment. And my results found that if a doctor were to be in a scenario where he had to give a secondary treatment, he could pick either IVIG or steroids depending on the circumstances, and it would be equally as effective according to my data. And my research is completely new and reliable data, as it is from a source that collates doctors' case notes, and it has never been studied before in this way to analyze the effectiveness of these treatments. And the results again show that there's no difference, and this strengthens the standard treatment protocol to say that both treatment works as effective to treat this disease. Thank you.
Thank you very much. So really quickly, any questions for Sanjay? Sanjay, I just had a question about the end. You just mentioned, given certain scenarios, doctors could choose potentially either or. Could you give us a scenario in which they would choose one over the other?
Yeah, for instance, steroids is often a cautionary medication given to children because steroids can often have side effects that are more long-term. Whereas IVIG is just pumping kids with more immune cells of what they already have. Steroids is introducing a new synthetic hormone that could possibly have side effects in the heart itself, in the leg, and the muscles. And so steroid is used as a more direct measure. It's equal in effectiveness, but there are side effects. So I guess with the patient's past history, a doctor can determine himself which treatment to use.
Thank you. Anybody else? All right, great. Thank you, Sanjay.